So since the first lens was implanted by Sir Harold Ridley, there has been tremendous advantage in the tools, technology, and training for the cataract surgery. We now have the wonderful phaco machines, femtosecond lasers, Zepto nanopulse technology, specular microscope, optical biometers, OCT scans to deliver the best outcome. One of the most important steps for cataract surgery is the capsular axis, and the capsular axis can be done by using the cystotome capsular axis forceps, a combination of cystotome and Vanna seizure, and recently the capsular axis can be done by femtosecond laser and the Zepto nanopulse technology. One of the most commonly used technique for capsular axis is 26 gauge needle cystotome, and using this technique it has several advantages, but in wide cataract sometimes it's difficult to achieve the capsular axis, and it is not uncommon to see the runaway axis or Argentinian flex sign for the less experienced surgeon, or even with the hand of experienced surgeon sometimes. In cases of anti-capsule fibrosis, one can use the Vanna seizure and the capsular axis forceps, which can help to achieve capsular axis in capsule fibrosis cases. Now we have several tools available to us in cases of difficult cataract surgery for doing capsular axis, which include femtosecond laser, Zepto nanopulse technology, and some other recently experimental devices. The femtosecond laser is one of the most exciting development in the field of ophthalmology during last 5 years. Dr. Ramamurthy will be sharing his experience on managing the difficult cases using femtosecond laser. The other experimental devices include the capsule laser capsulotomy, which is under the experimental stage right now. Maybe it may be available in next few years. And the another technique is thermal capsulotomy. So these are the experimental devices which are available, which will be available in near future. The Aperture continuous thermal capsulotomy is another experimental device which can help us to achieve the good capsular axis. And this device have the centering point for capsulotomy, and this is the video illustration showing the how Aperture CTC works for performing the capsular axis. This device is under experimental stage right now, and it may take a few years to come up for its clinical application. At present, the most commonly used method for capsular axis is the Vanna, 26 gauge needle and the Utrata capsular axis forceps. Today, I'm here to share my experience on one of the another way of doing capsulotomy is Zepto-Rhexis, which we have used in during last 5 years. The Zepto-Rhexis can be used in the adult as well as pediatric cataract cases. We have done approximately 10 cases in children using the Zepto-Rhexis. Today, this is my first case where we used the Zepto-Rhexis in a 5-month-old child. As we all know that performing capsular axis in a children is very difficult because of so many challenges. The capsule is highly elastic. Because of low scleral rigidity, there are high chances of the runaway axis, and it's difficult to perform the capsular axis because of the shallow antechamber and positive vitreous pressure. This is the technique of Zepto-Rhexis in a 5-month-old child. You can see the perfect capsular axis, which is done in few seconds using the Zepto device. The only limitation this device is that it has to be inserted inside the anterior chamber, and one should be careful while inserting this device in the anterior chamber, particularly in children, because it may cause some endothelial cell loss. So always use dispersive viscoelastic such as chondroitin sulfate based viscoelastic to coat the endothelium. And once you perform the capsular axis, other steps are straightforward. it's important to perform the primary posterior capsulotomy and anterior followed by staining of the vitreous in the using the time silicone. And this is our second case, 36-year-old case with the hypermature cataract, intumescent cataract. And in intumescent cataract, there are high chances of Argentinian flex sign or runaway rhexis. So femtosecond or Zepto-Rhexis can be helpful to achieve a successful capsulorhexis in intumescent or hypermature Morgagnian cataract, particularly those cases who are planning for the premium lens implantation, because for premium lens implantation a successful capsulorhexis is very important. And here you can see a successful capsulorhexis using the Zepto capsulotomy device. Once the capsulorhexis is done, then the other steps are straightforward, and this is, in this case, we are implanting the trifocal lens in the capsular bag. And the advantage of the Zepto-Rhexis in such cases that one can achieve the central rhexis of approximately 5.2 millimeter in size, and everything else became straightforward, simple after performing the successful capsulorhexis. Here, this is a case of hypermature Morgagnian cataract, which we planned for toric multifocal lens implantation. And you can see the Zepto handpiece being inserted using the 2.8 millimeter incision. You can see the silicone cup with nitronol ring, and notice that the presence of cortical milk once we perform the capsulorhexis. This cortical milk came out, and it's difficult to perform rhexis with the cystotome, or there are high chances of Argentinian flex sign in such cases. So once the capsulorhexis was done, the phacoemulsification was done, and then this was followed by implantation of multiple lens. This is another case of white cataract, and we use the intracameral injection of phenocaine, which is preservative-free, phenylephrine, and lignocaine, manufactured from some of the companies, Indian pharmaceutical companies. Notice that people started dilating after injection of the phenocaine intracamerally. We did staining of the entry capsule, and this is followed by the insertion of Zepto handpiece using 2.8 millimeter incision, and within few seconds the capsulorhexis is done successfully. One of the limitation of the intracameral phenocaine is that once you perform capsulorhexis, there can be meiosis of the pupil, or pupil may come down. So you need to use viscomydriasis to achieve pupillary dilatation. And here you can see the phacoemulsification is in progress, and the pupil is coming down, and one can achieve the viscomydriasis to achieve the good pupillary dilatation. So this technique of phenocaine application intracamerally can be useful for selective cases of those cases who has allergy to tropicamide eye drops. And here we are inserting ultracert preloaded lens. Preloaded lens has the advantage that this can be inserted through 2.2 millimeter incision, and the preloaded technology minimize or avoid any incidence of touching to the lens, optic or haptic, and it also saves time in the busy ophthalmic practice. So here you can see the lens being implanted in the capsular bag, and the pupil is smaller because of once we use the intracameral injection of phenocaine in this case. So so these are some of the advantage. We always use intracameral moxifloxacin in every case. And in summary, Zepto precision nanopulse technology is very exciting development. The limitation of this technology is that one has to insert the handpiece into the anterior chamber. There are some studies done comparing the endothelial cell loss compared to manual rhexis, and the preclinical studies did not reveal any statistical significant difference in the endothelial cell loss those done by the Zepto-Rhexis. And one of the important limitation is the cost also. So this is about my talk on Zepto-Rhexis. And
thank you, Dr. Pandey.